Well, hello. Welcome to the IMS ASCO EHA and myeloma treatment in a time of the COVID-19. I'm Susie Dury, and it's my pleasure to welcome you to the International Myeloma Foundation's live online webinar on ASCO and EHA and myeloma treatment in a time of COVID-19. So as I said, I'm Susie Dury, President and co-founder of the Foundation, and today we will learn more about the current trends in myeloma treatment and research with this update. Two major medical meetings held virtually in May and June of 2020. This one-hour webinar features a panel discussion led by IMF Chairman Dr. Brian Dury, and panelists are Dr. Joseph McHale of Translational Genomics Research Institute and IMF Chief Medical Officer. And we're glad to have Dr. Craig Cole of Michigan State University Breslin Cancer Center and member of the IMF International Myeloma Working Group. As you know, we are living in unprecedented and very challenging times. And as myeloma patients and caregivers, we also need to better understand myeloma treatment options while taking safety precautions from COVID-19. If you have not yet accessed tonight's slides, you can do so at www.myeloma.org. I'd like to thank our sponsors for their support of today's webinar: Amgen, Bristol Myers Squibb, GlaxoSmithKline, Janssen Oncology, Sanofi Genzyme, and Takeda Oncology. And now it's my pleasure to turn this over to Dr. Brian Dury. Brian?
Well, thank you for that introduction, Susie. I'm very pleased to welcome everyone to this ASCO EHA summary presentation. And as Susie mentioned, I'm extremely pleased to welcome today's speakers, Dr. Joseph McHale and Dr. Craig Cole, who can give their wisdom and comments about these new data that we're going to be hearing about. And as Susie mentioned, we're very pleased to have our sponsors for this, which make it all possible. And so the agenda for today is to focus, as I've said, on the top abstracts from both ASCO and EHA. As you probably are aware, both of these meetings this year were virtual meetings, but nonetheless, quite a bit of important data were presented and included late-breaking abstracts, immune therapies, which have been a hot topic, important trial updates, and then some smaller abstracts and presentations which touch on some clinically important points, such as the importance of slim crab and MRD. And then I thought, because of the current situation, it's important to always give a little bit of update and advice about challenges in this time of COVID-19, infection prevention, and how to make adjustments to ongoing management. And so, if we go to slide number 4, which is the first slide showing an abstract data, this focuses on late-breaking abstract number 3, which was definitely the main new data that people were looking for at ASCO this year. These are data that had not been previously presented. This trial of carfilzomib, lenalidomide, and dex, KRD, versus bortezomib, lenalidomide, and dex, VRD, has been going on for quite a number of years and accrued well over 1,000 patients. And so people have been anxiously waiting to see what is the outcome for this randomized phase 3 trial for newly diagnosed patients. And this was presented by Dr. Shaji Kumar. If we go to slide number 5, you can see that although this was for newly diagnosed myeloma patients, it did not include every patient. Patients with high-risk abnormalities were excluded from this trial, in particular patients with translocation 1420, 1416, deletion 17p, PCL, plasma cell leukemia, and elevated LDH. So those patients were not included in this particular trial, which did, however, include patients who had what's considered more of a better risk feature, translocation 1114, and an intermediate risk feature, the 414, which is a category of patients which frequently does better with proteasome inhibitor therapy such as Kyprolis or Velcade. The 1q plus chromosome abnormality was not assessed as part of this trial. It's important to note that this trial also excluded patients for whom there was an intent to go ahead and transplant right away. However, as we will discuss, patients in both arms of this trial did go ahead and receive transplant, typically a little bit sooner in the VRD arm versus the KRD arm. In this trial, patients with early disease identified by SLIM CRAB criteria were not included, only patients with symptomatic CRAB positive myeloma. And so the result was a bit of a shock, I think, for everyone. And if we look at slide number 6, the median progression-free survival, so that basically the length of the first remission was basically identical. KRD 32.8 months, VRD 31.7 months, and so this was really a decisive result, showing not the slightest semblance of a benefit for one of the regimens versus the other. What was different on slide number 7 is that obviously the treatment-related adverse events were different, with much more frequent impact on cardiopulmonary side effects and also some renal toxicities with the KRD regimen linked to the Kyprolis, obviously. And then, as we all know, much more frequent neuropathy with the VRD regimen. And so the conclusions in slide number 8 are fairly clear-cut. KRD does not give a improved PFS. Of note, however, despite that lack of PFS benefit and also a lack of overall survival benefit, deeper responses were seen with KRD. There was a higher level of achievement of VGPR and better. As I said already, the peripheral neuropathy occurred more frequently with the VRD, cardiopulmonary and renal toxicity with the carfilzomib. And so this leads to a final conclusion emphasized by Dr. Shaji Kumar. VRD should remain the standard of care for initial therapy for multiple myeloma. And you can see that we have embedded in this slide Dr. Kumar's actual ASCO presentation, which you can access if you would like to get more detail. And so if we go to slide number 9, I'm interested to hear from Dr. McHale and Dr. Cole. Is this all simple and correct? What about high-risk disease? What about early disease or older patients? Are there other things that we should talk about related to this trial, or is this kind of a closed issue now? So maybe, Joe, do you want to comment first?
Sure. Thanks, Brian. I'm happy to participate today, of course, and happy to comment on this. I sometimes joke and say you need endurance to wait for the results of the endurance trial because it took so long. I put several of my patients on this study almost 10 years ago, so that this has been a long study in coming. I would in general agree with the conclusions, but I think they were a little forcefully presented. I do think that we weren't overly surprised, to be honest, in the results, because the very place where we tend to use carfilzomib in frontline therapy are the very patients that are not here, which is to say high-risk patients and patients going to transplant. What this study, I think, was helpful is it reminded us that in that older, more frail population who are not high risk, VRD is probably still the standard of care. Although this didn't show us that VRD was better, it just showed that basically they were equivalent. So I think carfilzomib is still an option. I do think the way the cardiopulmonary or cardiorenal effects were lumped together is a little bit misleading. When we look at the absolute numbers, this is not very much different than what we typically see with carfilzomib, and I think we're getting better at managing those toxicities with carfilzomib. But overall, yes, this is what we're typically doing in a non-high-risk older patient who may not be going to transplant or not intending to go to transplant. I still think VRD is the main approach, but it doesn't answer the questions about can we use carfilzomib in younger patients, those going to transplant, those with high-risk diseases, which is, of course, where we tend to use it.
Right, exactly. So, Dr. Cole, what's your take on this? Any points you'd like to emphasize?
Yes. Well, thanks for inviting me, and I love the IMF. I've been a fan for a long time, and it's great to go over these trials. And I was really excited about this trial in particular because you're right. I've been waiting. It seems like for forever, and we've threatened Dr. Kumar with multiple forms of torture to get the data out of him, and then finally he presents it. And it's really important because out in the community there had been people who felt that carfilzomib containing regimens in this population was going to be superior, and this is the exact reason why we do randomized trials is to really clarify this issue that you can't really deny the data that came out, that really despite what people have felt, the data shows that for the population that was studied that it's equivalent, and that will be critical as we move forward into now doing trials with 4-drug therapy. So as we add antibodies on, a question had come up and when we were designing some clinical trials, what should the backbone of the next 4-drug therapy should be? Should it be a carfilzomib-containing backbone, or should it be a Velcade-containing backbone? And for these particular patients, I think for this group of patients, it really does tell us that the backbone part is going to be pretty equivalent. And I would say that the two issues I had with the trial is I would have loved to have seen that high risk data.
Exactly.
Because it's still, and even I kind of tend towards I look at those deeper responses that we're seeing in the carfilzomib containing arm, and I say, well, for my high risk patients, I think that's what I want to do. And so we talk about those options, but on the other hand, to have randomized data to really prove that we wasn't in this trial. And the other little issue is the early discontinuance. That there were a fair number of patients that were on this trial that had that didn't complete both the KRD and VRD arms. And a little bit more than what I see in my practice and in other clinical trials. And so, I think that that's one thing to kind of keep in mind. And of course, moving forward, the cost, because there's definitely a cost difference between these two regimens, and I think that's one of the biggest benefits is that we can see that with them being equivalent that we can now use other parameters in order to help our patients make a decision.
Exactly. So I think that for me, it is a big disappointment that high-risk group of patients, we still just don't have the answer there. And frankly, it's going to be difficult to get that randomized trial information at this point. I don't quite see where that information is going to come from, because moving forward, as you've commented, for quadruplet therapy, where we're looking to add daratumumab, probably that is going to be daratumumab combined with VRD versus KRD. And then for patients with transplant, who would be having early transplant, we don't have that exact answer if KRD could be maybe a better option. So I think some decisive information, but also some, unfortunately, missing information that leave some open questions. All right,
Brian,
so let's
can I
move
make
ahead.
one last comment about it?
Brian? Last comment, yes, please. Yes.
Yeah, last comment. Just Because I know, especially out of this, a lot of people ask and say, why did we exclude high-risk patients? And just to reassure people, we weren't trying to not include, per se, important groups of patients. But when we designed this study back in the day, and I had been involved with that, we designed two studies at the same time, one to be undergone by ECOG, this study, and a separate study undergone by SWOG, a different oncology group that, of course, Brian, you know so well because you've led major studies out of SWOG, which was looking only at the high-risk group, where those patients were given VRD plus elotuzumab versus just VRD. 10 years ago, we weren't really thinking that standard risk patients would need quadruplets. So that's why we hadn't really gone down that path for the non-high-risk group. And as you know, that study is presented at ASCO and didn't demonstrate a benefit of adding ELO. We do have a lot of frontline studies, as you've mentioned, that are including carfilzomib, but none that are directly comparing carfilzomib and bortezomib. Many of them are comparing, DARA KRD versus KRD, or isatuximab KRD versus KRD.
Right. Yeah. So I think that's true for sure. Yeah, I think that this idea of separating out the high risk, I think, in my mind at least, was kind of a flawed strategy in retrospect. But it was a major initiative coming from NCI at the time. Okay, so
Indeed.
Moving forward, a big topic for the last several years has been immune therapies, and these have been topics at ASH and ASCO for these last several years. At ASCO and EHA this year, major presentations occurred, as I've summarized on slide 10, on CAR T-cell protocols, bispecific antibodies, and antibody-drug conjugates, in this case specifically the GSK agent. And so if we just go through those different categories, as far as the CAR T-cell therapy, these are directed against BCMA, which is the B-cell maturation antigen, which is present on the surface of the myeloma. And these T-cells are the patient's own T-cells, which are engineered to target that BCMA on the surface of the myeloma. And so on slide number 11, you can see the best overall responses, which improve from left to right as you increase the dose or the number of the T-cells, the engineered T-cells that you give to the patient. The target dose was 450 times 10 to the 6, and that gave an overall response rate of 82%, which was the targeted benefit that was being looked for. And you can see as you move from left to right, there's more blue and orange, meaning that you're getting more deeper responses. And so the results, which have been presented before actually, on slide number 12, you can see that it's clear, deep and durable responses occur. The target dose of 450 times 10 to the 6 cells, that higher dose worked the best. And it was basically a tolerable therapy with manageable cytokine release syndrome, what we call CRS. And you can see the best response produced the longest remission, so that the PFS, the length of the PFS, like the light blue curve, you can see had the longer remission versus the other categories of response with not such deep responses. And we have the full abstract presentation embedded there, and you can look at the additional details. The other CAR T protocol on slide number 13 is what used to be called the Legend product coming from China. This was taken over by Johnson & Johnson and is now called JNJ 4528. Again, a BCMA-directed therapy. It's actually a double BCMA-directed CAR T approach. And again, produces very dramatic responses. This has been presented at ASH last December, and you can see on slide 13, 100% of patients achieved some degree of response, and this slide has really caught people's attention, where people have said, oh my gosh, this treatment is really working for every patient, even although they're relapsed and refractory. Well, that is true, but if you go to slide number 14, this is certainly not a panacea, so that in this CARTITUDE-1 trial, which is testing this particular product, the overall response rate was 100%. However, the stringent CR was 86%, VGPR 97%, so some pretty consistently deep responses. Over on the right, you'll see, however, that although some responses did deepen over time, you'll see that some red bars do pop up, which means that some patients did go from a deep response to having a MRD positive, which means that the myeloma did come back in some patients. And so this is not a cure, this is not necessarily a permanent remission, but again, you're seeing a high level, deep responses, and again, a well-tolerated, manageable cytokine release toxicity profile. There was another type of CAR T using fully humanized binders that was presented at ASCO, the EVOLVE protocol. And again, this is producing good results. And so you can see on slide 15 some comparison of the different numbers there. And so as it stands, the KARMA data are being presented at the FDA, and the CARTITUDE data will be presented to the FDA probably later this year, and we have to see where EVOLVE and a lot of other kind of second-generation protocols will move forward. A lot of excitement on slide number 16 with this newer bispecific antibody where the cartoon shows you that the antibody has a BCMA arm which binds to the myeloma. So the BCMA, the green one, binds to the myeloma, and then the blue one is split down the middle. You'll see, and it binds to the T cell. The CD3 binds to the T cell. So it brings the two cells together, which triggers the T cell to release a bunch of chemicals which help to destroy the myeloma. So a very clever and effective therapy. And this Teclistamab, you can see, has a pattern similar to CAR T cells. If you start at the bottom left and you increase the dose, if you increase the dose of this monoclonal antibody bispecific, then you increase the depth and the duration of the response. And so again, deep and some durable responses. So a tolerable bispecific in this case with some deep and persistent benefit. And so then the third type of monoclonal antibody or immune therapy rather, belantamab mafodotin, which is the drug conjugate. So this is a monoclonal antibody against BCMA, which has a drug conjugate, so that when the antibody binds to the myeloma, the drug goes into the myeloma and enhances the killing of the myeloma. And this GSK product has been tested for some time, and we've seen a lot of the results presented and published at ASCO and EHA. The results of this DREAM-6 study, which I summarize on slide 18, were presented, giving an overall response rate in the combination of the Bela with bortezomib and Dex, 78%. And so this is the way that this is moving forward to utilize actually slightly reduced dosing in a combination approach to get good response rates and an acceptable safety profile, with the big issue being some keratopathy, so with some effects on the eyes, which are reversible. But as you can imagine, anything that's affecting your eyes is something of a concern for a patient, and they want to be really sure how this will be managed and what will happen to the dose, etc. And so this therapy, in this case here, deep responses, and it's expected, since this is an ongoing therapy, this is not a one-time therapy, this is ongoing therapy, there's strong anticipation that there will be ongoing deeper responses over time, and so this will hopefully be the case. And so I'll be most interested to hear what Dr. McHale and Dr. Cole think about these various options. So what are the pros and cons of these different types, the CAR-T, the bispecific, and the drug conjugate? And will all of those have some future role, or how will we end up integrating these therapies? So maybe Dr. Cole, you might want to go first on this one.
Thank you. I'm laughing because I'm like just so excited about this. Because if you think about it, I mean, it was in 2015 that daratumumab as a single agent was approved, and then it was like, oh my goodness, this is an incredible drug. And in 5 years, we went from having response rates of saying that 36%, 40% response rates for refractory myeloma was incredible, to having these just amazing response rates for patients that have failed multiple drugs. So in 5 years, that is amazing, and which is going to make the future role of these therapies very interesting, because things are happening so quickly and the research is just phenomenal. But for the pros and cons, the CAR-T, it costs a lot, and that's a con. But it is a one and done therapy that you get the therapy and it does its job, and you walk in the hospital and then you stay a while, then you walk out, and so it's kind of a one and done. But it's really the durability that we have to think about, that we need to see more data on with the BiTE antibody.
So maybe the durability would be coming if you used it a little bit earlier.
Yes. And, with, the future role of the therapy, is this something that we put in place of transplant? Is this something that we do up front? If we do it up front, would the durability be so long we wouldn't need anything like maintenance therapy? I mean, those are incredibly interesting questions. And then what would be the cost to do this as upfront therapy for patients? The BiTE antibody doesn't cost as much, but it is a weekly therapy, so it's not one and done. The great thing about this particular BiTE antibody is that I think it's being studied as either subcutaneous or IV, which is an improvement over the continuous infusion fanny pack of BiTE.
Yeah, that was a problem for the prior product. Yes.
And then for the antibody drug conjugate, we have that trial here, and it costs less. There's no cytokine release syndrome, and on the study is given either on every 2 weeks or once a month, and it's very tolerable. It was studied in not as heavy a pretreated population as the other two, but it is, having given it, it's very easy, and I think my patients are more annoyed by having to see the eye doctor as part of the trial than actually any eye complaints.
That's good to know. That's reassuring. Thank you. Yes. So Joe, what is your take on these? I'm sure you have a number of similar thoughts, perhaps.
Yeah, I share Craig's excitement, and I think one of the things that has encouraged me the most, Brian, now we've seen it with CAR T-cell therapy, we've seen it with the T-cell engagers or these bispecifics, not quite with antibody drug conjugates because there's only one of them, but as we've seen newer versions of these agents and these processes come through, we've seen them not only get more effective, but also get safer. When we think of that first CAR T-cell trial in myeloma, I mean, it's tragic. A third of those patients succumbed to complications, and now we're seeing much better control. So I think the enthusiasm that Craig has, I mean, I always agree with Craig Cole anyway, but the enthusiasm that Craig has is definitely founded. My answer to your question of where they're going to fit is a twofold answer. Answer number one, I want them all, right? Meaning, a lot of people are debating, is it going to be CAR T? Is it going to be bispecific? Is it antibody drug conjugate? I think we want them all. In a disease that we've not yet really cured patients, we want as many options as possible so that we can tailor it to individuals. It's going to be hard for some people to ever get CAR T-cell therapy. They live far away from a CAR T-cell center. There's issues of pheresis. It's almost like going through a stem cell transplant. Some people are just not going to be eligible. Other people will prefer to have something that's close by that they can get either on a regular basis or, obviously, as Craig has mentioned, a one and done. The second way of thinking about where they're going to fit, and I agree with you heartily, Brian, is that I really do think we will bring these therapies, like we do with just about everything else, earlier into the disease course, not only because things work better earlier, but in particular, we know that the T cells get exhausted in myeloma after several lines of therapy. And so these drugs are likely going to be even more effective earlier on. I mean, we're not quite ready to drop transplant and our current strategies, but I think we'll see over the next couple of years, these drugs, kind of like daratumumab did, it cut its teeth after everything else had failed, and now we're bringing it right up to the frontline therapy. I think we're going to see each of these classes of drugs doing that. And as we go through, we're going to get better at it, be able to reduce the cytokine release syndrome. A lot of these bispecific therapies, we still have to admit patients for that first day. And I look forward to the day when we don't have to do that and we can treat people exclusively as an outpatient so that their quality of life is preserved.
Right. So I fully agree. Very, very exciting, and these therapies will definitely are going to be game changers, and used earlier can really have a big impact, and maybe move current autologous stem cell transplant out of that key top spot or routine use that we have right now. So anyway, we need to follow very, very closely. So let's move forward. At ASCO and EHA, a number of clinical trials were presented, and basically these are trials where combinations of 3 drugs were compared with doublets or 2 drugs, with the new drug being assessed as part of a triple therapy. And so I think that most people on this call are familiar with these kinds of trials now, and so quite a number were presented. Now, the first one actually was not that type of trial. It was, in slide number 21, was a CELMOD, which is basically an agent similar to an IMiD, but with a slightly different mechanism of action. And so its mechanism of action is such that it does work in patients who have previously been exposed to IMiDs, such as Revlimid or pomalidomide. And so there was a bit of excitement to see that this particular CELMOD, now there are several moving forward in trials, but this particular one, 92480, and relapse refractory myeloma, was showing some exciting benefit. I'll be interested in comments from Joe and Craig on this in these patients with prior IMiD exposure. So definite efficacy, and obviously in that same type of category as the IMiDs. Another trial, which is of the type I was referencing, the Boston study, there was a lot of excitement to just have the final results of this Boston trial, which was the combination of selinexor with bortezomib and dex versus the bortezomib and dex alone. And again, another different mechanism of action here, and it's exciting to have these agents with different mechanisms of action getting approved. So selinexor was recently approved, but this particular Boston study shows that as part of a combination, you really can get significant added benefit and sustained benefit. And so with careful use of selinexor as part of a combination, I think there's definite excitement that these data strongly support the use moving forward. Now, another trial was one that has been assessed for quite some time, and we're joking about the endurance trial. Well, in this case, you need stamina to assess the benefit of the stamina trial, which is a large study which looked at 3 ways of treatment after initial therapy, where patients would get lenalidomide as maintenance, they would get VRD and lenalidomide maintenance, or they would get a second autologous transplant. So patients would have a single autologous transplant and then a second one, or VRD, or just lenalidomide maintenance. So the initial results of this trial have been presented and published and showed, and again, this is a little bit puzzling, is that each of those arms produced exactly the same remission duration and survival. But with definite stamina, the investigators did not give up. They said, okay, well, how about if we just look at these stamina patients, looking at the treatment that was actually given to these patients, because not all patients would be able to go ahead and have a double transplant, one transplant followed by another. So if you look at patients who actually did receive an auto transplant and then a subsequent second auto transplant, what happened? And well, on slide number 24, looking at the data in this way, it showed up that particularly for patients with high-risk myeloma, this auto followed by another auto transplant did in fact give some added benefit in terms of PFS survival. And so this was interesting, and I'll be interested to see how my colleagues reacted to this information. A second thing which was observed, which I think is possibly even the most important thing to come out of this trial, is that patients who stopped taking the lenalidomide maintenance had the pattern of relapse that you can see on slide number 25, where when you stop the lenalidomide, patients do start to relapse, and gives strong support for the notion that long-term lenalidomide maintenance is really quite important to sustain remission. Okay, so the next trial, just going quickly through these trials, was the SWOG trial that Dr. McHale referenced. This is VRD or RVD, they call it here, plus or minus elotuzumab, and in high-risk myeloma, so just looking exclusively at the high-risk population. And so this was going on in parallel with the endurance trial. So the high-risk patients came into this trial, and it turned out that getting that ELO had, unfortunately, no added benefit. And so a next trial, which is quite exciting, that was presented for the first time at EHA, was the EHA trial, and Dr. McHale is an investigator on this study, and so it was exciting to see that the alternate monoclonal antibody against CD38 is Teclistamab combined with carfilzomib and dex, gives added benefit versus carfilzomib and dex in relapse refractory myeloma. So a very clear benefit for this, and so exciting to see an alternate anti-CD38 monoclonal antibody moving forward. And then I'm just going to go forward actually one more slide so that we do all the trials together. The final trial that I want to draw attention to is the Bellini trial, which is venetoclax, and so another mechanism of action. In this case, venetoclax is an inhibitor of BCL2, which is something that is expressed in patients that have the translocation 1114. And so those patients are particularly susceptible to benefit from this particular drug. So this trial has been presented before, but it was represented with a longer-term follow-up, and the combination of venetoclax plus bortezomib and dex was obviously better. The green versus the blue, basically a doubling of the length of remission. The problem with this trial was that benefit was really only sustained with a survival benefit, an overall survival benefit for patients with the 1114 and the high BCL2 expression. For the other patients, there was even a concern of a negative impact. And so this was one of those trials where there was a concern about benefit just in a subset of patients, which makes assessment a little bit trickier. And so if we go back to my listing, and we can add venetoclax to this list, so you don't need to comment on all of these trials, but out of this list, what were the most important observations that would be take-home messages? And who would like to go first on this? Dr. Cole, do you want to jump in first?
Brian? I can let Craig go as well. I'm happy either way.
Yeah.
So, with the CLIAMED study, I mean, that's fantastic stuff. I mean, we've been using, the Revlimid now for 20 years. It's kind of running around, and
right.
And now we have a drug that's directed exactly at Ikaros and Alios, the
right.
transcription factors that make myeloma run, and the target, the by mistake targets, because Revlimid was not designed. It just happens to inhibit that. This drug is designed to do that. So that, I think, in using that as future backbones is just terribly exciting. In the stamina trial,
so you really see that as something that could move in and maybe even replace IMiDs moving forward. You see it that strongly.
Yes,
yes.
I think that yes, I think
okay.
In the same way that I haven't driven the same car for 20 years. I think it's that we changing out our car for a stronger that's not necessarily true, but hopefully a faster, more efficient car.
All right.
May be the direction of the future.
All right. Sorry to interrupt.
Go ahead. I'm sorry.
So what about these other data? What strikes you as important?
So with the stamina trial, the one, two things. I mean, absolutely. I think I've always had the conversation with my patients about, when can I stop my maintenance Revlimid? When can I stop my maintenance Revlimid? Well, here is, proof that continuing your maintenance Revlimid until we know better is important. The dual transplant for the high risk patients, one little feature about the stamina trials, how they defined high risk, that patients that it was a broad sweep of what they call high risk, patients that had aneuploidy, patients that high beta 2 microglobulin, and then the usual fish suspects. And so, and the other thing is that I think, that we've known for decades now that with those high-risk patients that we usually put them on proteasome inhibitor as maintenance therapy. And I haven't been using Revlimid as maintenance therapy for high-risk patients based on older data. And so what this trial tells me is that I think that we could do, tandem transplants, but also, it would be nice to have seen what a proteasome inhibitor maintenance would have done for those high-risk patients.
Absolutely, yeah. Okay, so Joe, any strong comments here? I'm jumping in because we're going to be moving forward here, but some key takeaways from your standpoint?
So absolutely, I'll be very brief. I agree the CELMODs are important because they may help us overcome pomalidomide resistance, although I'm not sure they're going to replace them. Selinexor is much more tolerable when given once weekly in combination, and so I think the Boston study is very important because now we're going to be able to partner this drug like we had daratumumab single agent, now in combination. I agree with Craig and Stamina that we should be giving lenalidomide long-term. I do not at all believe their conclusions regarding tandem transplant. I think when you look at studies backwards like that and try to find a way that the patient was Capricorn and liked the color green and therefore a tandem transplant benefit, that did not seem to be the case. And last,
a bit skeptical about that. Okay.
Yeah, and then lastly, in the IKEMA study, I do think that this is speaking to a very potent CD38 inhibitor, very much antibody, very much like daratumumab. We'll see a lot of comparisons between the IKEMA and the CANDOR study, and it's just giving us yet another option to care for our patients in early relapse.
Right, absolutely.
And if I can just, with the Bellini trial, with using venetoclax for 1114, I mean, that is terribly, that's unbelievably exciting. That we now have, a target, a molecular target, BCL2 and 1114, that we can use moving forward. It's going to be critical to make sure with these studies, especially the molecular target studies, to have a broad sweep of patients involved in these clinical trials. One thing that we know about 1114 is that between African Americans and Caucasians, that there is a higher incidence of 1114 translocations than in African Americans. And so to have African Americans in these trials to make sure that we have enough patients with 1114 on the trials, and B, to see is 1114 in African Americans, when we actually treat, is it the same as it is in Caucasians and other races? And so I think that as we begin to narrow the scope and make our targets better, to have patients of a broad sweep of genders and races is going to be critical.
Absolutely. Some very, very important points there. Yeah. So a unique opportunity there, and an important opportunity. So what I'm going to do now is I'm going to be getting into what were some poster presentations at ASCO and EHA, just to comment on some small points. And so the first one on slide 30 was pretty interesting, which was that in the combination of daratumumab with bortezomib thalidomide index, so this French trial, DVTD, the interesting thing is that if you looked at patients with early disease identified by the new diagnostic criteria, what we call SlimCrab, there was a particular benefit with the 4-drug combination in patients with earlier disease, which is really quite interesting and important. And then a whole series of posters, actually both at ASCO and at EHA, looking at MRD testing and the role of mass spectrometry. Mass spectrometry is more sensitive than SPEP and immunofixation. Also, when it is positive, it does seem to be a strong predictor of early relapse. Another area of different abstracts was the conversion of patients. If you are MRD negative and you become MRD positive, obviously this does happen, and in this one study was happening in about 40% of the patients. So that achieving MRD negative is something to certainly achieve, but those patients need to have ongoing monitoring for sure. And so I'm actually going to skip forward just to give a flavor of the EHA abstracts. There were 15 orals and 123 posters. 6 of the orals were also presented at ASCO, and so there's quite a bit of overlap between ASCO and EHA, actually. The late-breaking abstract was that IKEMA trial, which we just were discussing. Other abstracts of note at EHA, there are quite a lot of genetic studies presented on the European side, including single-cell studies, quite a bit of data about MRD, also real-world analysis, looking at what happens when a protocol is actually utilized in a real-world setting and what was the quality of life. And then there were multiple abstracts on the use of ixazomib, the oral proteasome inhibitor Ninlaro. And then there were multiple DREAM trial results presented using the belamaf drug conjugate. One small point that was quite interesting presented by Peter Sonneveld was that in studying the bone marrow, they found that looking at single cells, that fibroblasts in the bone marrow seem to create a favorable microenvironment for the growth of the myeloma. And so they were pointing out that maybe targeting fibroblasts could be a new approach to help shut down myeloma, something new. And then moving forward here, there was a follow-up presentation using ixazomib as maintenance, an oral proteasome inhibitor or maintenance. So the tourmaline MM4 trial, again, showing that added benefit. So very, very encouraging about oral Ninlaro, which is quite encouraging, particularly in this time of the COVID-19 crisis. It means that an oral proteasome inhibitor can be considered, and we have evidence of benefit and efficacy. Okay, so some final points just in a broad discussion about where are we with myeloma therapy, and unfortunately, as much as we want to look the other way and to move forward, as we're seeing in these last couple of weeks, this COVID-19 pandemic is not going anywhere. And so on slide number 37, what should myeloma patients be doing? What should we all be doing to try to help shut this COVID-19 down? For sure, wear a mask, and the best mask that you can come up with. And number two, and this can make a huge difference, avoid crowds indoors and try to physically distance. These things are so important. And so a couple of articles that you can look at your leisure. Very important to know that asymptomatic individuals are spreading this COVID-19. This study I reference here showed that the average length that asymptomatic individuals were shedding virus was 19 days, so almost 3 weeks that asymptomatic people can be shedding COVID-19 virus. Another key point is that young people who might be out going to rallies and restaurants and then coming home, they can be spreading infection when they come back home within the household to vulnerable individuals. And this is a very, very common source of problems and spread that everyone needs to be aware of. And so some summary points. Right out there in the community, most individuals are still not being infected, and so they can be getting infected and then passing it on to you. So limit new contacts, avoid crowds, wear a mask, physically distance, focus on outdoor activities, certainly avoid group travel, and be very alert about dangerous situations for sure. And then as far as myeloma management, things that we've talked about a lot, a recent study showed that patients with MGUS do not seem to be at a particularly high risk, although patients with myeloma and ongoing active therapy certainly do have some increased risks with COVID-19 infection. Smoldering myeloma is probably somewhere in between, depending on the exact status of the smoldering. But key things, and Craig, this is incredibly important. Some of these cofactors are just so much more prevalent in Black Americans with increasing age. The occurrence of hypertension, diabetes, and chronic diseases can really increase the risk for a variety of reasons that these end up being the cofactors that are present. Many of these being quite disturbing, but these factors are so important, increasing the risk, pushing us towards use of telemedicine when we can, and I know, Joe, that you're very interested in this, is that although we're concerned about autologous stem cell transplant and CAR T cells, we don't want to be stopping doing those. It's very, very important to control the myeloma, but they certainly need to be done with new protocols and new cautions so that we are doing these in as safe a fashion as possible. And if we can substitute oral therapies, let's do it. It was remarkable to see that dexamethasone is helpful in the treatment of serious lung disease in patients with COVID-19, particularly patients on ventilators or requiring oxygen. So if Dex is being used as part of a therapy, that's probably okay, but that doesn't mean that patients should be taking Dex, because there obviously are many risks in taking Dex. So I'm not saying that patients should take Dex, but if you happen to have Dex as part of your protocol, that is probably okay. But big picture, remember, the top thing is to keep your myeloma under control, continue with your therapy, continue with your maintenance, as we've been discussing, and try to do your very, very best to stay safe. This is a tough time for all of us. Hopefully, on slide 41, resilience will get us through this, but you have to take time for yourself. You have to not ignore your social network, which is illustrated in this picture here. Take advantage of your social network to help bolster your strength and to have a discussion about best action plans. And so we need to work hard to stay safe and have the best strategies for all of our patients with myeloma. And so I've gone through this last part just in a summary fashion, but perhaps Joe and Craig, you can give some final thoughts about where we are with myeloma therapy and what is this impact from the COVID-19 in your mind. So perhaps, Joe, you want to go first?
Sure. Thank you. Thank you, Brian. That was a brilliant summary of a lot of complicated topics. You know, I would want to leave as a take-home message that COVID has not stopped myeloma research and work, and we are still fighting very hard for our patients in this disease. I have seen unbelievable resilience, not only in our patients, but also in all of us who are taking care of both COVID patients and indeed myeloma patients. So it's easy right now to let everything get us down, but the number of approvals from the FDA, the number of clinical trials presented really gives us hope for the future. I do think that within a year's time, we're going to see more and more different ways of attacking myeloma. And in the interim, I think your key point of making sure that we do our best to take care of our myeloma patients while taking all the precautions that I've mentioned is really important. We haven't abandoned care of myeloma. I, in many respects, am seeing more patients now because I see many of them virtually. I've been doing consults from all over the world virtually, and in some way, we feel more connected. And I love the way you always say it, Brian. You are not a fan of social distancing. You're a fan of physical distancing and social connectedness. And I think that connectedness is really important going forward, because this isn't something that's going to pass in the next week or month or even a few months. It looks like it'll be with us for a while. So this new normal we need to contend with. We do hope it'll come to an end. We do hope a vaccine will come. We do hope we'll have ways to really get rid of this virus. But in the interim, we're still fighting with you and encourage you as you go through. And I'm very optimistic for the future.
Thank you. Thank you. So Dr. Cole, your thoughts?
Yeah, that was a fantastic presentation, and you showed so much science, and it really does highlight the importance of clinical trials and research, and how much hope that gives us. I was talking to one of my patients yesterday about how it feels sometimes that we're, in the caboose of a runaway train, but really, having, 530 people on this, seeing the science and learning about this disease and seeing the hope and the unbelievable advances that have happened in such a short period of time really does empower patients, and it puts them as the engine and has the disease in following along. And that's empowerment of both in myeloma and in COVID is really important. And so, the biggest part about all the research that you presented is that it's presented to myeloma patients, and so they can have that sense of autonomy and being able to discuss these findings with their physicians at home. And for COVID, this too shall. My grandmother, she's always told me this too shall pass. And out of what passes, we will be smarter, more efficient, better. And I'm very hopeful for the future, because also there's so much science that is going on with COVID, so that we'll have, we'll be well armed coming this fall, and super well armed for any other viruses that come our way. But thank you for inviting me, and thank you for everyone listening tonight or today.
Well, thank you so much for that, and thank you so much, Joe. So obviously, I agree with these final thoughts. I think that the science is incredible, and the science is marching forward and tremendously encouraging. We're going to see so many important advances as we bring in these new immune therapies and a number of those other agents that have been touched on here today. And despite the COVID-19, there's tremendous research going on related to that. And I think that if we work together to all stay safe and to try to maximize access to all of these different opportunities moving forward, this can be the best of times in a very difficult time. If we work together and try to stay resilient and strong. And so thanks to everyone for participating in this teleconference today. I'll turn it over to Robin Toohey, the leader of our support group program, who will have some final comments for everyone. So thank you.
Sure. Thank you, Dr. Dury and Dr. McHale and Dr. Cole. Some things that I learned and really appreciate are the more mechanisms of action that we have today, are different ways and new ways to attack the myeloma. So just picturing that and thinking of those combinations, that's great hope. And again, the importance of maintenance and participating in clinical trials. And then from COVID-19, what struck me was this 19 days of shedding the COVID virus. So please wear those masks and keep yourself safe. And about today's webinar, don't forget that the replay of this webinar will be available early next week. And from our weekly series, Dr. Dury, to comprehensive news and key myeloma medical conferences around the world, the IMF videos are really your all-access tickets to critical myeloma research, patient education, and guidance. And it's so much more interesting and hopeful to watch these videos than more TV, right? So please continue to learn at each step of the way, wherever you're at. Contact the info line, because while we're not in the IMF office and working from home, the IMF info line is open and available. So that number again is 1-800-452-2873, or you can email them at infoline@myeloma.org. And we're so thankful to Paul and Missy and Judy, and keep those good questions coming. Speaking of which, Dr. Dury, I'm not sure if we have time for questions at this point, or we're going to ask all questions go to the info line.
I think that would be the best, yeah. Yeah, I think that's the best. But we're just to emphasize that we're we're tracking these. We have these here, and we're very, very glad to follow up so that we can get different questions answered. Yes.
Okay, great. And I want to also, on that point, just a special shout out and a reminder to everyone that while your local support groups are not meeting in person, that they are meeting virtually to continue to support their local community. So please check with your leaders to find out what that meeting schedule again. And I don't want to forget to thank our sponsors that continue to make these valuable calls possible, and they are Amgen, Bristol Myers Squibb, GlaxoSmithKline, Janssen Oncology, Sanofi Genzyme, and Takeda Oncology. And of course, thanks to all of you for taking the time to be on this webinar. We hope you found it helpful to stay informed and resilient despite these uncertain times. So stay safe, be well, and again, keep wearing those masks.
Absolutely. So thank you, Robin.
Thank you, Robin.
Stay safe, wear your mask, and stay informed. So thanks to everyone.
And this is Susie signing off. Thanks to all of you, and we're always here for you, so don't ever hesitate to just, send us an email or give us a call.
And thanks again to Dr. McHale and Dr. Cole for setting aside their time to provide their valuable input here. So Thanks again. Bye-bye.